This part of the Toxidrome sessions will focus on cocaine and amphetamines. By the end of this session, you should be able to recognize the features of the sympathomimetic toxidrome. You should also be able to give examples of substances that can cause this toxidrome and formulate an approach to managing sympathomimetic toxicity. Here's a case to start. This is a 25-year-old woman found collapsed at a party. Her GCS was 11, heart rate 155, blood pressure 160/94, respiratory rate 36, and a temperature of 40.1 degrees Celsius with an oxygen saturation of 89% on room air. Her pupils were also noted to be 8 millimeters in size. What toxidrome is this, and what exposures could produce this type of clinical picture? It's clear that the patient in this case has a number of key vital sign abnormalities, including tachycardia, hypertension, hyperthermia, and tachypnea. This case actually has features that could be seen with several toxidromes, and this presentation should make you think of the anticholinergic, sympathomimetic, as well as several of the withdrawal syndrome toxidromes. The anticholinergic and withdrawal syndrome toxidromes have been briefly discussed in the other video sessions. The sympathomimetic toxidrome is characterized by hyperthermia, tachycardia, hypertension, tachypnea, mydriasis, diaphoresis, as well as CNS excitation that can lead to seizures. Any one of these vital sign abnormalities can be life-threatening, but it's the hyperthermia that is the most dangerous. There are a huge number of exposures that can produce a sympathomimetic toxidrome. Cocaine and amphetamines are probably the most classic examples. Amphetamines can include prescription drugs such as those used for attention deficit disorder, as well as a number of street formulations, including methamphetamine. Ecstasy, or MDMA, has both sympathomimetic and hallucinogenic properties, but will produce a predominantly sympathomimetic toxidrome in overdose. The street drug PCP, or phencyclidine, is also sympathomimetic and can present with extreme agitation in addition to the other features. Cat is a stimulant plant containing cathinone that is used culturally in East Africa and Arabia. Many of the newer street drugs, such as synthetic cathinones or bath salts, and synthetic cannabinoids, otherwise known as spice or K2, can present with a predominantly sympathomimetic toxidrome. It's also important to remember that other exposures can produce sympathomimetic features, including methylxanthines, nicotine, ASA, and withdrawal syndromes. Going back to our case, our patient admitted to using cocaine. Cocaine blocks the presynaptic reuptake of neurotransmitters, including norepinephrine, dopamine, and serotonin in the brain, which produces the classic sympathomimetic toxidrome that we saw in this case. It also has local anesthetic effects due to sodium channel blockade, which may also affect the cardiac conduction system. In addition to the sympathomimetic toxidrome, cocaine produces end-organ toxicity through vasospasm, ischemia, and hemorrhage. Vasospasm can affect the coronary arteries, central nervous system, retinal artery, pulmonary artery, GI tract, or limbs. Ischemia can produce problems including ischemic colitis, and hemorrhage is probably most catastrophic in the central nervous system. Rhabdomyolysis is common in conditions that produced hyperthermia and agitated delirium, such as cocaine toxicity and other sympathomimetic exposures. The management of cocaine-induced toxicity is similar to other exposures that produce the sympathomimetic toxidrome. The cornerstone of therapy is supportive care, including ABCs and aggressive fluid resuscitation, to account for losses from agitation and hyperthermia. Benzodiazepines are often required in high doses and should be used to reduce psychomotor agitation and for seizures, and have been associated with a decrease in mortality. They can also be effective for cocaine-associated chest pain and can be used together with nitroglycerin in place of beta blockers. In general, beta blockers should be avoided to prevent complications of unopposed alpha receptor stimulation, although there is some controversy around the use of beta blockers in cocaine-associated acute coronary syndromes. Rapid external cooling should be a priority for all hyperthermic patients and can include ice packs to the groin and axilla, cooling blankets, or submersion in an ice bath. Complications of drug-induced hyperthermia are life-threatening and include multi-system organ failure, rhabdomyolysis, acute renal failure, and disseminated intravascular coagulation. Cocaine-induced tachycardia is due to centrally mediated release of epinephrine and is typically sinus tachycardia, but wide complex tachycardias may also develop due to the sodium channel blocking properties and can be treated with sodium bicarbonate. This has been a brief introduction to the sympathomimetic toxidrome and cocaine toxicity. Here are a few questions to help further your understanding of these issues. What are the differentiating features between a sympathomimetic and anticholinergic toxidrome, and how would these different toxidromes change your initial management and possible consideration of antidotes? What are other complications of crack cocaine use, and what types of treatments would these patients require?